Assalamualaikum everybody, I hope you all are doing well. Today we'll be talking about Mycobacterium tuberculosis, how it is responsible for causing tuberculosis, its morphology, and others. But before getting into the video, I'd like to tell you guys that these videos are meant for educational purposes. Things and treatments may change with time. If I get wrong or miss anything, your input is always welcomed in the comments section. So, have a cup of tea and let's get started. Let's talk about the pathogenesis. Humans breathe in all sorts of viruses and bacteria all the time. Humans got defenses that take off most of them. The air we breathe in is turbulent in the upper airways. It drives most bacteria against the mucus, which are then cleared quickly. Mucus is found in the upper airways, which is responsible for clearing these microorganisms. Now let's talk about Mycobacterium tuberculosis. It enters lungs via inhalation, and it avoids the mucus traps and makes its way to deep airways and alveoli, where macrophages live. Macrophages eat foreign cells, digest, and destroy them. They recognize the foreign proteins on bacterial cell surface. Then what happens? Mycobacterium tuberculosis is phagocytized or packaged into a small space called phagosome. If this was any other bacteria and was a normal case, then what would happen? That phagosome would fuse with the lysosome, and lysosome has hydrolytic enzymes that can break down any biochemical molecule. But here we've got TB, so this is not the case. TB produces a protein that inhibits this fusion, the fusion of phagosome with the lysosome. As a result, Mycobacterium survives, proliferates, and creates a localized infection. Here you can see the growth and proliferation of Mycobacterium tuberculosis within the macrophage. And it is damaging the macrophage. There it is bursting and causing the infection in the lung. Now, this is the primary tuberculosis. This is mostly asymptomatic, or some people might show mild flu-like symptoms. After 3 weeks of infection, cell-mediated immunity kicks in. This is how the cellular immunity looks like. The CD4 positive T cells are the Th1 helper T cells, along with the macrophages and other T cells, and the interferon gamma. This type of reaction is the type 4 hypersensitivity reaction. After 3 weeks of infection, this is the Mycobacterium tuberculosis and it has caused primary infection. And after 3 weeks of infection, the cell-mediated immunity has kicked in. Now, what happens? Granuloma is formed. Granuloma is formed to wall off the bacteria, prevent it from spreading, and is formed by the immune cells. Here you can see the macrophages. These are the immune cells around the granuloma. The tissue inside the granuloma dies. This is now called caseous necrosis. Caseous necrosis means cheese-like necrosis. And the dead tissue is soft, white, and looks like cheese. This area is now known as gone focus. Then what happens? TB also spreads to nearby hilar lymph nodes. Spread to hilar lymph nodes is either carried over by immune cells through the lymph or by direct extension of the gone focus infection. Caseation is caused there as well. Together, this caseating tissue and associated lymph node make up gone complex. Gone complexes are subpleural and occur in lower lobes of the lungs. This tissue that is encapsulated by granuloma undergoes fibrosis and often calcification, producing a scarred tissue that can be seen on X-ray. Calcified gone complex is called a Ranke complex. Sometimes immune system kills the mycobacteria, leaving only a scar. Other times the bacteria stay alive but dormant, walled off by the body. If the immune system is compromised, either by AIDS or aging, the gone focus may reactivate. Reactivated TB can spread to one or both upper lung lobes. This occurs because TB and aerobe prefers areas with higher oxygen, like the upper lobes. Due to prior exposure, memory T cells quickly release the cytokines to control the reactivation. This leads to morcaceous necrosis, often with cavity formation, called cavitation. Cavities allow TB to spread through airways and lymphatics, causing bronchopneumonia. It can also spread via the bloodstream, infecting multiple organs, a condition called systemic miliary TB. Systemic miliary TB involves different organs and causes organ-based complications. Like if it involves kidneys, it will cause sterile pyuria, which means loss of white blood cells in urine. If it involves brain, it will cause meningitis, which is the inflammation of 3 protective layers of the brain. And if it involves lumbar vertebrae, it will cause Pott's disease. If it involves liver, then hepatitis. If adrenal glands, then Addison's disease. And if cervical lymph nodes, then lymphadenitis in neck, also called scrofula. Lesions are dependent on the presence of the Mycobacterium tuberculosis and the host, the human response. There are 2 types of lesions. Number 1, exudative lesions, which consist of an acute inflammatory response and occur chiefly in lungs at the initial site of infection. Number 2, granulomatous lesion, which consists of a central area of joint cells containing tubercle bacilli, surrounded by a zone of epithelioid cells. These joint cells, called Lange's joint cells, are an important pathologic finding in tuberculous lesions. Clinical findings. Clinical findings are varied, and many organs can be involved. Constitutional symptoms, such as fever, fatigue, night sweats, and weight loss, are common. Primary tuberculosis. It is asymptomatic, or if some people show symptoms, they'll show mild flu-like symptoms. Pulmonary tuberculosis. In pulmonary tuberculosis, the main findings are cough, hemoptysis. Hemoptysis means blood in sputum, and scrofula. Scrofula is mycobacterial cervical lymphadenitis, presents with a swollen, non-tender lymph nodes, usually unilaterally. Lymphadenitis is the most common extrapulmonary manifestation of tuberculosis. Patients infected with human immunodeficiency virus, the HIV, are more likely to have multifocal lymphadenitis than those not infected with HIV. Next up is gastrointestinal tuberculosis. This is characterized by abdominal pain and diarrhea, accompanied by more generalized symptoms of fever and weight loss. Intestinal obstruction or hemorrhage may occur. The ileocecal region is the site most often involved. Tuberculosis of gastrointestinal tract can be caused by either Mycobacterium tuberculosis when it is swallowed after being coughed up from a lung lesion. Next one in the list is oropharyngeal tuberculosis. This typically presents as a painless ulcer accompanied by local adenopathy. Then we've got renal tuberculosis. This presents with dysuria, hematuria, and flank pain. Sterile pyuria is a characteristic finding. The urine contains white blood cells, but cultures for common urinary tract bacterial pathogens show no growth. However, mycobacterial cultures are often positive. Hematuria means blood in urea. Dysuria means pain during urination. Flank pain is the pain in the flank regions. And sterile pyuria means white blood cells in urine. Then we've got these symptoms. Let me explain them. Erythema nodosum. That is characterized by tender nodule along the extensor surfaces of tibia and ulna. It's a manifestation of primary infection seen in patients who are controlling the infection with a potent cell-mediated response. Then we've got miliary tuberculosis, and it's characterized by multiple disseminated lesions that resemble millet seeds. Then tuberculous meningitis and tuberculous osteomyelitis, especially vertebral osteomyelitis, the Pott's disease. Moving on to the next slide, we've got lab diagnosis. We'll definitely need some samples to diagnose this bacterium. We'll go for sputum, we'll go for blood, and bronchoalveolar lavage. On microscopy, we'll find out that this bacterium does not stain with gram staining. Instead, it's stained with acid-fast stain and leaves a bright red color with Ziehl-Neelsen stain. We can also go for Kinyon version of acid-fast staining. For rapid screening purposes, auramine stain, which can be visualized by fluorescence microscopy, is used. This bacterium is rod-shaped under the microscope, as you can see there. It is 0.2 to 0.5 micrometer in diameter. In addition to performing an acid-fast stain, the specimen should be cultured. After digestion of the specimen by treatment with sodium hydroxide and concentration by centrifugation, the material is cultured on a special plate, such as Lowenstein-Jensen agar or Middlebrook agar, for up to 8 weeks. It will not grow on a blood agar plate. In liquid, Bactec medium, the radioactive metabolites are present, and growth can be detected by the production of radioactive carbon dioxide in about 2 weeks. A liquid medium is preferred for isolation because the organism grows more rapidly and reliably than it does on agar. You know what? Why the time is 8 weeks? Because the growth is too slow. And if the organism has grown on the culture plate, it will look something like this or this. If growth in culture occurs, the organism can be identified by biochemical tests. For example, Mycobacterium tuberculosis produces niacin, whereas most no other mycobacteria do. It also produces catalase, so we can easily diagnose it. Then we've got certain other tests. We'll go for X-ray, the chest X-ray. The chest X-ray findings in reactivation tuberculosis of lung include an infiltrate in the upper lobe with or without a cavity. Next, we've got purified protein derivative PPD skin test. Let's talk about that. The purified protein derivative intradermal skin test, also called PPD skin test, tuberculin skin test, Mantox test, TB test. It needs a test read later. Okay, why it needs that? Because we inject something into the skin and after a day we then look at that and we make our diagnosis. So that's why it needs a test read later. What's its procedure? Tuberculin is a thing that is injected into the skin. If the person was previously exposed, immune system reacts within 48 to 72 hours. And a large area of induration is formed. And this is how the induration area looks like, kind of red and circular. Then we can say this is a positive test. This is about 15 mm and this is the positive Mantox TB skin test. The third one in the list is biochemical tests. We've talked about that. If the growth on culture plate is seen, then we can go for that. Then we've got PCR, the polymerase chain reaction. We've also got NAT, the nucleic acid amplification tests. These can be used to detect the presence of Mycobacterium tuberculosis directly in clinical specimens, such as sputum. NATs are available that detect either the ribosomal RNA or DNA of the organism. These tests are highly specific, but their sensitivity varies. In sputum specimens that are acid-fast stain positive, the sensitivity is high, but in smear-negative sputums, the sensitivity is significantly lower. These tests are quite useful in deciding whether to initiate therapy prior to obtaining the culture results. Then we've got luciferase assay, which can detect drug-resistant organisms in a few days. And luciferase is an enzyme isolated from fireflies that produces flashes of light in the presence of adenosine triphosphate, the ATP. If the organism isolated from the patient is resistant, it will not be damaged by the drug. Instead, it will make a normal amount of ATP, and the luciferase will produce the normal amount of light. If the organism is sensitive to the drug, less ATP will be produced and less light is produced. Next, we've got interferon gamma release assay, IGRA. Interferon gamma release assay, it's an alternative test to the tuberculin skin test. or the PPD skin test. It looks for previous exposure to TB proteins, and this is a blood test as compared to the PPD, which wasn't a blood test, and tuberculin was injected into the skin. This test does not need the test read later because it shows results as we do the test. This is more specific to TB as compared to other mycobacterial infection. There are two versions of this test. Number one, quantiferon TB Gold, and number two, T-spot TB. In interferon gamma release assay, blood cells from the patient are exposed to antigens from Mycobacterium tuberculosis, and the amount of interferon gamma released from the cells is measured. The sensitivity and specificity of interferon gamma release assay are as good as those of PPD skin test because the antigens used in the test are specific to Mycobacterium tuberculosis and are not present in BCG. The test is not influenced by whether a person has been previously immunized with BCG vaccine. An important thing to mention here is that IGRA and PPD tests are positive in both latent disease and in active tuberculosis. So any person with positive test must be evaluated for the presence of active disease by obtaining a chest X-ray and a sputum sample. One important thing to mention here is that IGRA and PPD tests are positive in both latent disease and in active tuberculosis. So any person with positive test must be evaluated for the presence of active disease by obtaining a chest X-ray and a sputum sample. Treatment. Okay, I won't get into much detail, but to be honest, it's going to be really easy the way I'll tell you. Isoniazid is used for both latent and active infection, while the remaining three with isoniazid are used for active infection. The remaining ones include rifampin, pyrazinamide, and ethambutol. Although therapy is usually given for months, but the patient's sputum becomes non-infectious within 2 to 3 weeks. Now let's talk about the drug-resistant strains. There are two kinds of resistant strains. One is MDR-TB, the multi-drug resistant TB. And the second one is XDR-TB, the extremely drug-resistant TB. Special regimens are used for these two types of strains. Prevention. Better housing and nutrition, using N95 mask and other respiratory isolation procedures. This mask is quite important. An important component of prevention is the use of PPD skin test to detect recent converters and to institute treatment for latent infections. Then we've also got quantiferon TB Gold, the QFTG. This measures the amount of interferon gamma released from the patient's lymphocytes after exposure to antigens from Mycobacterium tuberculosis in cell culture. This test requires only a single blood specimen and determines the amount of interferon gamma by an enzyme-linked immunosorbent assay, ELISA test. BCG vaccine. This vaccine can be used to induce partial resistance to tuberculosis. This vaccine contains a strain of live attenuated Mycobacterium bovis called Bacillus calmette-guerin. The vaccine is effective in preventing the appearance of tuberculosis as a clinical disease. Pasteurization of milk and destruction of infected cattle are important in preventing intestinal tuberculosis. Alright everybody, let's have a quick recap. The organism we discussed today is Mycobacterium tuberculosis. It is responsible for causing tuberculosis. It can be active or latent. Mode of transmission is via inhalation. Its hosts are humans and it can also cause infections in cattle. Diagnosis is based on microscopy, culture, chest X-ray, PPD skin test, interferon gamma assay, and certain other tests. For treatment, isoniazid, rifampin, pyrazinamide, and ethambutol are used. And that's it for today's video. I hope you've learned a lot of things about Mycobacterium tuberculosis. If you've got any suggestions, feel free to leave them below in the comments. I'd be happy to read them. And if you want to connect with me on my social media, I've got my Instagram and Twitter, both with the handle medzukhruf. And I'll see you soon in the next video. Till then, Assalamualaikum.